Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Go to reallifepharmacology.com, get your free 31-page PDF on the top 200 drugs. Great study guide, great refresher, things that actually happen out in practice, as well as a lot of stuff on there that will show up on board exams and pharmacology exams. So simply an email will get you access to that at reallifepharmacology.com. All right, the drug of the day today is Meclizine. Brand name of this medication is Antivert. Bonine is another one that comes up as well. Antivert's probably the more common one if a brand name is utilized there. Over-the-counter generic names, you may see this labeled as kind of motion sickness pill. So, naturally that's one of the potential indications of this medication. Classifications, it's an antiemetic, so prevents, nausea, upset stomach. Its primary mechanism of action is it is a H1 receptor antagonist. So that's a histamine 1 receptor antagonist, and it is a first generation antihistamine. So with that classification, it falls into similar class as diphenhydramine, for example. So indications, motion sickness, and vertigo. Those are by far pretty much the only two things I see this medication used for. Maybe occasionally PRN or as needed for some nausea, that type of thing. But again, pretty rare. I typically see it with nausea associated with motion. And then that issue with vertigo as well. And mechanistically, that makes sense. One of the biggest things that Meclizine does is that antihistamine action. It suppresses vestibular end organ receptors. And if you remember, that vestibular system, that's in the inner ear, and that helps the mind-body navigate that balance and spatial orientation. So again, you can often hear when patients have inner ear infections, they, may be extra dizzy, that type of thing. When there's issues with that space, that part of the body, it can cause significant symptoms of, dizziness and nausea and things of that nature. So that's how Meclizine works, kind of to affect that vestibular system. Dosing of this medication, 12.5 to 25 milligrams every 6 to 8 hours as needed. So when using it for motion sickness, obviously we're going to time that dose appropriately. So, the absorption by the time onset takes place, it's going to be at least 30 to 60 minutes before that drug gets into the systemic circulation significantly and obviously gets to the site of action. So if we're using this medication for motion sickness, we better make sure that we're giving it at least 30 to 60 minutes before we are going to experience that motion, whether it's driving, flying, whatever the case may be. Maximum dose up to 100 milligrams per day. I can't say I've ever seen a patient get to that high a dose on that, but I'm sure it's happened. Probably most common I see is 25 milligrams, with lower dosages potentially in older patients there for adults. All right, adverse drug reactions. So, antihistamine, older generation, it's got a lot of anticholinergic adverse effects. Now, this typically isn't too big of a deal unless you're taking this medication on a chronic basis, which I have seen for vertigo. I have seen this medication scheduled. So if that's the case, obviously we're probably a lot more likely to run into adverse effects than, somebody taking it, once a week, once a month for motion sickness or something like that. So paying attention to those adverse effects, let's discuss those a little bit. So the anticholinergic effects, you can't spit, see, pee, or poop. So dry mouth, visual changes, urinary retention, constipation, those can all happen with Meclizine. Those anticholinergic effects are dose dependent, so higher the dose, more likely you're going to encounter those adverse effects. Confusion can happen, fall risk, sedation can happen as well with Meclizine. Again, higher dose, as well as older age, we're going to have a greater risk of running into those potential adverse effects. As I'm discussing this medication, I mentioned elderly. So this medication is on the Beers criteria. And again, that's a list of potentially inappropriate medications in geriatric patients. So again, it falls on that Beers criteria list because of its significant anticholinergic activity. Those anticholinergic adverse effects can be a significant cause of polypharmacy. I see this a ton. So, can't spit. Potentially, you could see a medication like, artificial saliva added. Can't see, dry eyes. You could potentially see artificial tears, maybe a Restasis type product, prescription type product for dry eyes. Urinary retention. So, this can obviously mimic or cause symptoms of BPH in males, that type of thing. We could potentially see, a medication like tamsulosin started to help relieve urinary retention. Can't poop or constipation. Naturally, we could see some laxatives added there. And then, of course, confusion, in the right patient, that could certainly mimic signs and symptoms of dementia and lead to the prescribing of acetylcholinesterase inhibitor like donepezil, a medication used for dementia. So really, really want to point that out, that this can precipitate or cause the prescribing cascade and the prescribing of other medications to kind of cover up or manage the adverse effects of this medication. So really, really pay attention to that. It's definitely something that comes up on board exams, recognizing those adverse effects, those anticholinergic adverse effects. Speaking of board exams, go check out meded101.com/store. We've got study guides, resources, all sorts of great stuff there that have helped thousands of pharmacists and other healthcare professionals pass their pharmacology and board exams. So go check that out. Support the sponsor, meded101.com/store. All right, finishing up with drug interactions. The first one I will mention is, to a certain extent, Meclizine is broken down by CYP2D6. The extent of how much Meclizine is broken down by this enzyme, I wouldn't call it major, but it could cause those Meclizine concentrations to rise a little bit if we inhibit the activity of that enzyme. So, classic example being bupropion inhibits CYP2D6. So adding that on top of Meclizine could potentially raise Meclizine concentrations. I'll also put in a plug in here about pharmacogenomics, making sure that you do understand that. If you've got alterations in the CYP2D6 enzyme, let's say you've got a patient that's a poor metabolizer at CYP2D6, so that would potentially cause Meclizine concentrations to be higher than they would in a person with normal functioning CYP2D6 enzyme that breaks down drugs. Okay, if they've got an ultra rapid acting or an ultra rapid metabolizer at CYP2D6, we could potentially have lower concentrations or action of Meclizine, and that might be more likely to lead to treatment failure, the drug not working, for example, there. So just wanted to make that note. Pharmacogenomics, definitely can play a role here, and definitely a reason why you might see some interpatient variability in response and the risk for adverse effects of certain medications. All right, drug interactions, additive anticholinergic meds. I definitely think about that with Meclizine. So if we have, other first-generation antihistamines on board, let's say the patient starts taking diphenhydramine for sleep, for example. Well, now we're getting dual anticholinergic medications. Obviously can have additive effects there. Tricyclic antidepressants, A drug like amitriptyline, nortriptyline, these are highly anticholinergic, definitely could lead to some additive type adverse effects. Other medications, some of the urinary anticholinergics, oxybutynin, for example, another good example there of adding on to some of those anticholinergic side effects. Even a drug like clozapine, classically kind of housed in the second generation antipsychotic group. Clozapine has some significant anticholinergic activity as well. BPH, I alluded to that a little bit. Keep in mind that anticholinergic meds like Meclizine are going to directly oppose the potential benefits of a medication like tamsulosin or finasteride that tries to shrink the prostate. Constipation, we can have some additive effects there. So I think of opioids, for example. Anticholinergic medications and opioids together going to greatly increase that risk for constipation. CNS depressant additive effects. So this is a huge swath of medications that can cause sedation and have that CNS depressant type effect. Meclizine can add to that. Classes like benzodiazepines, many of the sleeping type medications, insomnia type medications, Z drugs, trazodone, so on and so forth. Opioids, certainly, oxycodone, morphine, so on and so forth. And then alcohol. Alcohol intake could certainly exacerbate the sedative properties of Meclizine as well. The anticholinergic action can slow down the GI tract, so if we're trying to manage gastroparesis with a medication like metoclopramide, it can basically directly oppose that action. QTC prolongation, I don't stress about too much with Meclizine, particularly if you got a patient just taking it every once in a while on an as-needed basis. But it is something to think about, particularly if you've got a patient at high risk for that. Maybe they're on other high-risk medications that prolong that QT interval. And then last but not least, I alluded to the risk for dementia and increasing symptoms of confusion. So that can directly oppose some of the acetylcholinesterase inhibitors like donepezil, for example. All right, well, I think that's going to wrap up the podcast for today. Do me a huge favor, leave a rating, review on iTunes or wherever you're listening. Greatly appreciate that. Share us, friends, colleagues, other healthcare professionals, anyone who's looking for pharmacology education. Greatly appreciate that. If you've got any comments, suggestions, feel free to reach out to me, mededucation101@gmail.com. And if you're looking to purchase something, looking for more education, go check out meded101.com/store. Tons of resources there that can help you become a better healthcare professional. All right. Thank you so much for listening. Take care, and I hope you have a great rest of your day.